Good afternoon. My name is Felicia Taylor. I'm the CEO for the New Jersey chapter of the American Academy of Pediatrics. Thank you for joining us for this presentation on New Jersey's early intervention system and the role of the pediatric provider during COVID-19 and beyond. This is the first of 2 Think Babies webinars made possible through funding from the National American Academy of Pediatrics. We thank them for supporting our efforts to address health issues of children 0 to 3 years of age. But before we get started, I'd like to go over a few housekeeping items. Today's webinar will last for 1 hour. All attendees will be muted throughout the webinar in order to minimize any disruptions to the presenters. If you have any questions related to today's presentation, please submit them through the Q&A box on the webinar control panel located at the top or the bottom of your screen. Any questions remaining unanswered at the end of the webinar will be compiled and answers provided to participants a few days following this webinar. CME and MOC Part 2 credits are being awarded for your participation in this webinar, and a link to the webinar quiz will show in your browser at the conclusion of the webinar and will also be emailed to you tomorrow. Once your quiz is submitted, your credits will be issued and you can expect your certificate mailed to you within 30 days. This webinar is being recorded and will be made available on the NJAAP website. The information to access this webinar will be sent to you in an email after the completion of the webinar. So without further ado, it's my pleasure to introduce to you our presenters for today's webinar. Dr. Joseph Holohan is a graduate of the New Jersey College of Medicine and Dentistry. He completed his pediatric residency at the medical school in Newark and completed a 2-year fellowship in developmental pediatrics and care of handicapped children. In 1979, Dr. Holohan joined St. Joseph's Hospital and became the chief of the developmental pediatrics section of the Department of Pediatrics and the medical director of the Child Development Center. He is the associate chair of the Department of Pediatrics at the St. Joseph Children's Hospital. Dr. Holohan serves as chair of NJAAP's Committee on Children with Disabilities. He and his wife, Nancy, who is also a developmental pediatrician, have 4 children and 6 wonderful grandchildren. Our next presenter is our Dr. Jennifer Blanchette McConnell. Dr. McConnell is a member of the New Jersey Early Intervention System statewide professional development team as a training and technical assistance coordinator. She received both her master's and doctoral degrees in social and developmental psychology from Rutgers University. Her background is in infant child development and developmental evaluation, and she has achieved the New Jersey endorsement in infant mental health. As a clinical mentor, she has taught at both levels, the graduate and undergraduate level, in addition to providing numerous workshops and presentations statewide. Jennifer has been employed at the Central Jersey Family Health Consortium for the past 21 years within the Mid-Jersey Cares Regional Early Intervention Collaborative. Now, without further delay, it is my pleasure to turn the presentation over to Dr. Holohan. Dr. Holohan, it's all yours.
Thank you. Good morning. It's nice to present. You know, let's see if I have the control of the slide. I don't yet. I'm just going to let you look at the topics of the presentation and the learning objectives for a minute. But it's all available to you. And there is a poll question. How do you want them to answer that now? Okay, I'm going to start. This webinar is so important because You know what? Maybe you should control the slides because I don't have the control of them. You have to give me the click back again.
And just click once on your screen.
Oh, just one. I don't need the.
Yep. There you go.
Oh, I have an idle time expired here. Okay, this webinar is so important because the prevalence of developmental problems in children is so high, and the need for early identification and early referral for services is so imperative to really improve the outcome, not just short term, but long term. School accomplishment, occupational accomplishment later on. 1 in 6 children is diagnosed with a developmental delay or developmental disorder in the first 5 years of life, and even a higher percentage of children are at significant risk for developmental problems. And the importance of recognition and support services for those children is paramount as well. The American Academy of Pediatrics has emphasized developmental surveillance and developmental screening very much over the past 10 to 15 years. The recommendation is for developmental surveillance to be incorporated into every health supervision visit, and standardized screening to be accomplished at designated times, 9, 18, and 30 months of age, with a specific autism screen at 18 and 24 months, but also developmental screening at any time when there's a concern that occurs during surveillance regarding the possibility of a developmental issue that needs to be addressed. There are 6 components to developmental screening: asking the parents about developmental concerns, obtaining a developmental history, observing the child, identifying strengths and risks, documenting findings, and communicating with other professionals or agencies providing support and care for the child. And I'll go over some components of each of these that I think are especially important. Asking parents about developmental concerns. You know, many parents are hesitant to bring up developmental concerns. I think sometimes adults are hesitant to bring up concerns and hope that things they're worried about will get better on their own with nothing surfacing. So many parents have said to me over the years that I really had concerns about Johnny's, I'm going to use Johnny today, about Johnny's development, but thought if the pediatrician didn't say anything, that probably was okay. And I just think that it's difficult for some families to appreciate how much a pediatrician and the pediatric staff have to incorporate into an office visit, and how many areas you need to look at, and how important it is for them to highlight concerns. It's much more likely that parents will bring up developmental concerns if they're gently encouraged and if it's in a trusted relationship, the pediatric office and the medical home. It's very helpful to start with a positive approach. What does Johnny do well? What are you pleased about? And then to ask, are there any areas of his development that you're concerned about, or you think that he may not be doing quite as well as other children do? And it's worth asking too, has anyone at his daycare program or within your family raised any concerns about any aspects of his development? Just that nudge is an awful lot to a lot of parents in beginning to speak about something that they're concerned about, but very worried about and very reluctant to bring up. There are some wonderful developmental resources available. Bright Futures tool and resource kit, the pre-visit questionnaire. These are not the standardized questions that go into the screening. These are part of surveillance. And for parents to download, to have at home, to perhaps do in your office while they're waiting to come in. The CDC also has wonderful resources. Learn the Signs, Act Early, a milestone tracker. Whoops. These really help parents think about development and realize that the pediatric office is a very appropriate place for them to bring up their concerns. A lot of times when I ask parents, did you speak to the pediatrician? They at least often enough, they say, no, I really didn't see that as an issue that the pediatrician would be that involved with or concerned about. I thought the pediatrician was more to deal with medical issues. So I think there are some families that don't realize that this is the location to bring up developmental concerns, and the questionnaires and the items really not only help them realize that it's something that's germane to the pediatric office and that the pediatrician and the pediatric staff are concerned about, but it can promote their knowledge about child development. The questionnaires really help parents who maybe didn't realize how much a child at 18 months is doing to begin thinking about, you know what? Children at 18 months are really pointing to pictures, or naming objects, or naming body parts. Johnny's not really doing that. Maybe we should talk about that. And the other thing that's so important is that parents usually are correct about concerns they bring up. There's a lot of data that supports that. They may not know the reason why. And at the very end of the talk, I have a couple of things I want to bring up about that, but they usually are correct that there is something wrong. I guess the corollary is that parents not having concerns is not nearly as reassuring. A lot of parents are so good at facilitating development that they really don't realize sometimes that there are significant problems that they're not aware of. As valuable as developmental surveillance is, there's a lot of data that shows that without formal screening also, about 50% of children with developmental concerns will be missed prior to kindergarten. The developmental screening items that really should follow any concerns with, should be incorporated at those ages. I said it at any times when there's a concern, really help highlight specific areas of development. Often, even if a pediatrician and a family is astute and conscientious and careful about developmental questions and asking and bringing up concerns, it's easy to miss developmental issues within a specific developmental avenue, such as adaptive skills, without having a specific questionnaire that screens each area more definitively. And mild but concerning delays can easily be missed. And I think just mentioning too that with almost every developmental condition that affects children, the vast majority of children tend to cluster in the mild range and mild but significant range. And, children on the autism spectrum, there's much more children at the milder end of the spectrum than at the more severe end of the spectrum. And a mild autism spectrum disorder is a prominent concern that needs to be identified early. One other component of developmental surveillance is observing the child, and I'll come back to this a little bit later, but social engagement, alertness, attention, activity level. Just recently I had twins in the office. One of them had a mild degree of an autism spectrum disorder, a high functioning autism spectrum disorder. The other one was a typically developing child. Watching them together was just so incredibly apparent how different the child on the spectrum was. He actually named letters and numbers and shapes and colors. It was a beautiful, handsome little boy, but he just didn't reach out to engage. He played very much alone. He didn't make an effort to connect with his parents, to show his parents things. He didn't respond well without someone going right over and getting his attention. But in a quick visit, it could be easy to miss. And so looking at that, and we'll come back to the documentation, how important that is. And within the examination, areas of concern, that should be highlighted include concerns about head circumference and the rate of head growth, child's tone and reflexes, especially if there were developmental or familial or neonatal issues that raise concerns. A premature baby that had an intraventricular hemorrhage, for instance, even a small one. Movement patterns is something that's very important and easy to miss. If you just picture a typical child, even a 6, 7, 8, 9-month-old, they move with such a fluid ease. They flex and extend, and they move from one position to another so comfortably. Children with early motor dysfunction tend to be so much more rigid in their patterns of movement and so much less flexible in how they move. Recognizing dysmorphic features or features that look different than the family, especially within the context of other developmental or medical issues such as congenital heart disease or an unusual growth pattern. And looking at risk factors is so important. You know, I remember many years ago when I was actually in my fellowship, there was a strong emphasis in trying to identify one single easy way to identify children with developmental concerns. And our psychologist was looking at visual attention, how long a child sustained their attention, and did they hold attention longer than 10 to 20 seconds or so on a novel stimulus. And when they finally looked at all of the different items, it was poverty. That was by far the most important predictor of developmental concerns. And so risk factors from poverty to single parents, domestic violence, parent mental illness that so much can sap their energy and enthusiasm in working with their children make an enormous difference. And one of the things that's a very important part of developmental surveillance is documenting findings. I think if you can flag concerns, even if you feel that the issue is below the level of something that you would refer right now, highlighting it, that you did have a little concern about the rate of head growth. There is a concern that there's a family history of attention disorder. There is a concern that the child was a little bit less socially responsive than you thought would be ideal. Because later on, if you start to see a couple of other things that look a little bit concerning when you look at their development, let's say, in their speech, and you can look back and say, you know what, this is not the only concern. Actually, I did have a couple of other concerns as well. It can really make the difference with a child who you might be inclined to wait to refer, to decide, you know, it would be much wiser to refer now and be sure there's not a problem. And referral to early intervention is so important, and so often children are referred later than is ideal. Actually, New Jersey is still one of the lowest states in the nation with inception of early intervention services within the first year. And so I think we need to do more to try to move children into the system who will really benefit from it earlier when they can benefit the most. And I wanted to switch gears a little bit to, you know, one of the other items in the developmental surveillance was taking a developmental history. And, you know, the parent questionnaires and the screening help so much, but still sometimes things we see during that developmental questioning of the parents is so important. By far, developmental speech is the most frequent developmental concern in children. About 8% of preschool children have significant concerns with speech. And there's a lot of data that shows that with normal receptive language and with normal nonverbal development, children with delayed speech have an excellent prognosis. And so it's easy sometimes, and it's tempting sometimes when a little boy at 18 months or 20 months or so, or even a little girl, but maybe a boy more so because boys have speech issues more frequently. When they present with a speech delay, to say that, you know what, there's a lot of boys this age that have speech delays, and so many of them do well in the long run. Let's watch a little bit. We'll see them in 6 months. I think we have to be concerned that there's not a delay with receptive language. Speech itself is immersion of speech is much more variable in when it comes out versus receptive language. Receptive language skills are much less flexible and much more fixed in children. If there's a developmental problem with receptive language, if the children don't seem to understand, there's much more often a real problem than not, whether it be hearing loss or developmental language disorder or autistic spectrum disorder, intellectual deficiency. Don't wait with the child with delayed speech. I just make the point that the child on the high end of the autistic spectrum is so often a verbal child who's very good with labeling things, letters, numbers, shapes, colors, dinosaurs, animals, but you can't have a conversation with them. And in the program, if you ask them how are they in, you know, a library, a mommy and me group, or in a daycare program, much more often than not, they're off on their own doing their own thing, and the parents will tell you that. Important milestones, and I make the point that, you know, at 9 months to a year, a lot of language milestones are beginning to emerge. You know, the first word is around 9 months in many children, but there's a lot of receptive language that's also emerging. Understanding their name, understanding no, maybe not always complying with no, but understanding no. Playing simple games, peekaboo, clap hands, bye-bye, are all emerging at that time. In another month or so, children are beginning to look at named objects. Where's the window? Where's the fan? Where's the light? Where's daddy? And it may, you know, over the next couple of months, these skills are really emerging. There's a whole plethora of receptive language skills that are very well developed in the vast majority of typically developing children by a year and before a year. And I will make the point, remember before I said that parents are very accurate usually when they raise the developmental concern, but not nearly as accurate when they don't have concerns. With telemedicine in the last couple of months, it's just so apparent when you do some of the assessments by video auditory, that the parents, good parents, do so much to facilitate the development of their child and the performance of their child. They use gestures, they use prompts, they run ahead to show them what they want. And so they don't realize, you know, I have sometimes, a lot of times, children sitting in the, parents sitting in the office with a child, and they're concerned about speech. And I say, do you think they understand? Okay. And they say, sure, doc, he understands everything. And I say, well, would you mind asking him to get you a car from the shelf and bring it over to you? And they jump up to run over, and I say, no, stay where you are. Just ask them from here and try not to point initially. And some of the children, especially the kids on the mild end of the spectrum, don't even respond, turn to their name, let alone follow their request. But I think parents who do so much facilitation at home just don't realize it sometimes. And in the next, we know that kids at 21 months and oh, I'm sorry, let me go back 1 second. At 21 months, kids are starting to combine words, and at 24 months, starting to use sentences. But 6 months earlier, there's a whole bunch of receptive language that children should be showing that, again, is not very variable and not very flexible. They should be following directions. They should be pointing to body parts. They should be pointing to pictures. And I would be concerned not just with the child who doesn't have any phrases by 24 months, but a child who's not responding to their name and doing simple games or pointing at 12 months to a couple of months after that is so important. I think parents don't realize sometimes how important gestural language is, and the kids on the spectrum usually are not showing that. Following directions at, I'll just make the quick point that kids, a typical child at 12 to 14 months is pointing so much. I remember, it said in the beginning, we have 6 grandchildren. Our daughter-in-law told us when one of our grandsons was 14 months that his pointing is out of control. He's just pointing to show me everything. And it's just so missing, glaringly missing in children with social emotional impact, social emotional problems. And I just wanted to highlight some non-causes of speech delay, because these are some of the reasons too parents think that children may not be speaking and kind of will dismiss it. A bilingual background will not account for speech delay, nor will everyone speaking for a child or doing everything for him, being stubborn. Isabel Rapid at Einstein, a wonderful neurologist, used to say children don't speak because they can't speak, not because they won't speak. His father or his uncle spoke late. That might be an okay reason if they understood, but if the child doesn't understand, people in the family speaking late is not an okay reassurance. Being twins, birth order issues, whether they're first or last or in the middle, really don't change significantly language development or development. And tongue tie rarely might affect articulation, but not account for lack of words or not account for receptive language problems at all. Refer early if you're concerned. I would have to think back to years, actually, to hear a parent say, you know, I'm annoyed that the pediatric office or the pediatrician referred my child early and there turned out to be no problems. Everyone says, I respect that they were concerned about development and looked out for the best. And when you say that, you know, I have some concerns that Johnny isn't doing some things as well as most children his age do, and if we can identify that early and provide services early, it's so much better to do. And early intervention will evaluate your child and help decide, is there really a problem that needs to be addressed? Are there some supports they can give you? Almost all parents respond positively to that. You can refer to other services, but do the early intervention referral at the same time. And there's a number of resources that you'll have access to later on. The first two are wonderful courses that provide a whole lot of detailed information regarding the types of tests and what to do, the types of screening instruments that are available. And the last one, a very good article that you'll have access to. Thank you, and I'm going to stop here and change over to Jennifer.
Thanks, Dr. Hallahan. Can everyone hear me? Okay. All right. Someone will let me know if you can't hear me. So thank you. Really excited to be here. And I just wanted to say I'm really here representing a team of people from the Department of Health, which is the lead agency of early intervention, from the Mid-Jersey Cares Regional Early Intervention Collaborative, but I work with the other 3 regional early intervention collaboratives, and we work as a team. So what you're going to see is really the result of our teamwork. So our referral number you're going to see a few times on the slide. Hold on a second, it didn't take. Okay, so the first thing is, are we open? And yes, we are. Early intervention only closed for 2 weeks at the end of March to prepare for telehealth services, and so that's the big question. We are open, providing telehealth, jumping in, and I actually have some quotes to share with you about what families, their experience, which mirror what Dr. Hallahan was talking about. So you're probably not surprised that our referrals did dip quite a bit, and we're building back up. This is the most recent referrals. So at one point we were around 560 referrals, and now we're back to around 311. So I know it mirrors a lot of what's going on. Families have a lot going on, and it mirrors maybe they're not going out to their pediatrician's visits as much, but it is building back. And I think that's largely due to some of you who might be on the call continuing to refer families. So you may have seen some of our notices and information that in social media that we're open. I hope you could see the whole screen. Okay, role of pediatrician, Dr. Hallahan talked about how important pediatricians and healthcare providers are, that parents really do rely on pediatricians for information about child development, and the recommendations around screening are there. So as you can see, our highest referral source is by far healthcare providers and physicians, and this is something we've been working on over the past 10, 20 years building. So thank you to those of you who continue to share information with families about referring to our system. So that is the good news. Yet, as Dr. Hallahan mentioned, there are still barriers. Sometimes families will say that they have developmental concerns, but they weren't necessarily elicited. So this is based on some national data that more families are, that more pediatricians are doing developmental tracking, but a lower percentage are referring when there is an identified developmental concern. And then that third bullet is referring to the chart over here that is talking about, particularly in New Jersey, for the lower, we have a lower number than the national average of children under a year who are in our system. We're doing pretty good on our birth to 3 numbers, but given how the percentage of children who may have delays, we still may be missing children. So that was part of our purpose in meeting today. So we're going to launch our first poll to try to identify what some of the barriers are to early identification and referral to New Jersey's early intervention system. So if you go ahead and pick an answer, I believe you can pick more than one answer. I think they're going to show the results in a minute when people are finished voting. So you see there the idea about time and reimbursement rates, which we can't necessarily do much about, although some of our resources might help you with some of the time issues. But a lot of what the national data showed was, you know, just needing more information about what happens, how to call, what our eligibility criteria is, what's the process, are we effective, you know, and that I think that second to last bullet refers. So let's see what you guys came up with. Very interesting. So the highest, needing more information about early intervention. So again, people may know some, but knowing more information about the system, which is what we're going to cover the rest of the day. Tracking reimbursement, time and reimbursement. And again, some of the materials and resources hopefully will be helpful with the developmental tracking and really providing materials for families to use to facilitate that conversation. And then knowing more about development, pretty much you guys, that's a lower percentage. And this, I'd be curious to see what the other is, so maybe people can drop that in the chat box. But also this idea of not wanting to alarm families. And we do hear that from families too, family surveys as well. Am I able to move? Oh, there we go. So we're going to talk a lot about what our system is and how to get in, our eligibility, but also hopefully give you some information that referring earlier is always better. And hopefully Dr. Hollihan gave you some things to think about. So early intervention is called New Jersey's Early Intervention System, NJEIS, but we are technically Part C of the federal law that covers special education. So we're a bit under the Individuals with Disabilities Education Act. So that's the part that's for children birth to 3, and then children ages 3 to 21 are what's called Part B, or that's special education. So I'm probably think you heard of it. It's not moving forward. There we go. But the goals of the federal legislation are really aligned with a lot of what we know about the evidence base. So you can see here the idea of finding, just letting people know we exist. I call it getting in the funnel. You know, we start by saying, hey, let's make sure people know about us. Not everyone will be eligible, but everyone will get some information and they need to know about development. So that's what we're doing today, for example. And the second one and the third one really capture our focus on families, that the federal legislation is talking about the importance of early intervention and supporting the capacity of families. As Dr. Hollihan talked about, I was pleased to hear just that how we're seeing on telehealth that families really are really good at facilitating and supporting their child's development, and they may not even know some of the good things they're doing. So we really are family-centered. So the child has to be eligible, but we really are focusing on the whole family, the siblings, grandma, grandpa, childcare providers. We're really there to work on that, and then supporting children through transition. So these are some of the stated goals of early intervention, and there's lots of data that talks about how early and intervening early helps with long-term outcomes. It's also economically more efficient. We, make sure that kids are doing better earlier. And it has to do with brain development. So you see here how important our mission statement is. Hopefully the orange is jumping out at you, that we are really there to enhance the capacity of families to meet their child's developmental and health-related needs. And part of how we do that is by coordinating with families. We know that early experiences affect how the brain's developing. So I don't know, hopefully some of you have heard of this, but this idea of serve and return, that responsiveness between the parent and the child makes a sound, the parent notices, makes a sound back, the child makes a sound. I know we've seen some really cute videos recently on social media that kind of went viral, but you can see that idea of the back and forth interaction is literally building children's brains. And so we want to take advantage of that. That's why we work with families and to enhance their capacity. So that kind of tells you a lot about what the focus of our services and our evaluations and our meetings and our planning is. So it really is a statewide system where families and the system are really working to, I talk with my hands, I don't know if you could see this, but I'm gonna do it anyway, this idea of engaging and exchanging, really partnering with families to share ideas. They may not notice, and we say, oh, see, that's how you responded to him, or you named that for him, and then he did this. All those things are helping to build their capacity and their confidence and their ability, because parents really are the most important influence on the child's development. Parents and family, people who are in the child's life. And our plan is individualized. This is just a little overview of the early intervention system. There's a lot of us. I mentioned before the Department of Health is the lead agency. There's a state interagency coordinating council. We welcome some of you may be able to join or at least be aware. It's an advisory board. Dr. Hallahan's a part of that. There's also a procedural safeguards office to ensure families' rights are followed. And if families have a concern that they can, or a complaint, that they have a way of resolving that in a formal way. We also have a lot of ways they can resolve those any concerns informally. I work at one of the REICs, so I'm here, and then there's 4 of us in the state, and then I'm going to talk a lot more in detail about the service coordination and the early intervention programs and what their role is. This just is pointing out the counties that are covered by each of the 4 regions, and I just wanted to mention some of the materials we're going to show you, particularly our developmental brochures, might be of particular interest. If you, they have developmental, I'll show you a picture and there'll be a link to them, but I'll, when you get the follow-up email, but we'd be happy to provide additional brochures for you to have. They have what to expect developmentally and when to be concerned for all areas of development. So we've found those very helpful. Okay. I know we have a short amount of time and there's a lot of information here. I just don't want you to get overwhelmed. We put a lot of it in here so that you have a resource and a place to reference when you go back. And so we're going to hit a couple highlights, and there's a lot of steps in our process, but this is here the overview. So our system point of entry, how to get in, that's our referral, evaluation assessment, and that's focused on the child. So that's their developmental evaluation. I'm going to focus a lot on those beginning pieces of our process. But then there's another piece that really captures that family-centered nature, that not only, once the child's eligible, not only do we find out what's going on with the child, what are their strengths, what are their challenges, we do the same thing for families. We conduct family-directed assessment, which is essentially a family interview to find out what's important to them, what are they concerned about, giving them a voice. We want to make sure we're working on their priorities, and there's a whole meeting dedicated to that. By the service coordinator is going to be the family's point person for that. Then we develop an IFSP, or an individualized family service plan. I wish I could kind of bold that or put it in bright letters. It's really a plan designed to address the child's developmental needs and how to support the family to address the child's developmental needs, as well as other things that might be going on, linking families to resources. Of course, we then implement the plan and transition. So that's your quick overview. I'm going to give a little more detail. These are the public expense services. That means that these are provided at no cost to families. I'll talk later about services that might be subject to a cost share, and I'll explain that. But basically, child find, service coordination, which is the parent's point person, a comprehensive multidisciplinary evaluation, and IFSP, both initially, and then we review the plan as is needed, and then procedural safeguards. These are always at no cost to all of our families. And these are families' partners. So in the beginning when they call, the referral service coordinator is going to do a phone interview. I'm going to talk about that. And then the evaluation team does the child evaluation assessment. And then for children who are eligible, the two on your right, the ongoing service coordinator, and we call them early intervention practitioners, but we have about 20 different personnel titles. It could be child development specialists, special educators, OTs, PTs, speech language pathologists, nurses, social workers, behavior specialists. I'm sure I forgot somebody. But there's a variety of people with background in child development that may be working with children and families. Okay, so really important, the referral, supporting the family to make the referral. So like we said, asking them about their developmental concerns and sharing information about how to refer to early intervention. They call an 800 number and leave a message, and then they get responded to within 2 business days by our SPO referral unit, our system point of entry. So it's usually, we find it's most helpful for a family to call and leave the message for a couple of reasons. One, it's easy to get back to them and make sure they know about the referral, but also it really empowers them to take the first step. You certainly at an office could help the family call, but even if you call for a family, we'd have to make sure that the family knew about the referral. So we don't really want you to do it for them. We really want you to more support families to make the call. But there is some part of our federal legislation is to refer as soon as possible within 7 days. So as soon as possible and noticing a concern. So again, you could just see that the focus is not to wait, not to hesitate, but to share information, and that families will get good information during the evaluation, whether or not they, or the child is eligible or not, they still get some nice information and strategies. I don't want to belabor that too much, but I just want to make sure the 800 number, leave a message, and then we call the family back. We do not need a prescription or a referral or anything like that from a doctor. We certainly would like to, if the family would like to share information about their medical records, anything that you've seen, we're certainly able to share information, but the family has to decide. And that's why the family's sort of at the middle here, as the family and child in the middle, that they don't exist alone, but that families have to make decisions, get to make decisions about who they share information with. In general, we always would encourage families to, for there to be coordination and collaboration. I like to think about it takes a village. You know, you have your child care, your early intervention, your health care, your community, your extended family. But since we are a voluntary system, parents do have the right to accept or decline participation. And again, to me, it's really about empowering a family to seek the resource and then kind of build their confidence. And anyway, I could go on, but I'm gonna move on. So we can share information if the family signs consent, and we talk about that during the planning. Who do they want to share information with? This is just an overview of what the child evaluation assessment process looks like. We do use 2 different disciplines who would look at all areas of development. We use the Battelle Developmental Inventory, 2nd edition, which is a standardized tool. We use informed clinical opinion, parent interview, and review of medical records. So observation is a really important component of developmental testing. And then we are working within children's home and child care. So for right now, and we determine eligibility. For right now, we are using telehealth. So we're looking at all areas of development, and we're still using tools that are appropriate to be used for telehealth. So I wanted to share a little bit of information with you about telehealth, and there's a link there. I just put a screenshot to show, and with the link to a video that's a national video, to kind of get a sense of what it might look like. But really, the evaluation is very similar. Evaluators are trained in what they're doing, and they're going to talk. They're going to ask the parent to interact with the child, maybe in very specific ways, kind of saying, hey, don't point, just ask with your words, you know, things like that Dr. Hallahan mentioned. And they're going to just observe. And as he mentioned, you could see a lot through observation. You get a good sense, and we're getting actually really good feedback about our telehealth evaluations. And I think I have a quote coming up but I'll show you families are responding very well. I just wanted to let you know during the evaluation, children can move around. They don't have to sit in front of a screen. I think that's a little bit of a myth, that we may actually guide them. Our team might guide the family to set up the video camera so they could see the whole room. And sometimes they actually feel like they're getting a better sense of the child and how they're functioning within their family because they're not there to kind of interfere. So that's what it looks like. So if you wanted to take a look at a couple of the quotes, some of the words that jump out to me are family feels supported and felt like we got a clear picture during telehealth evaluation. The second one is talking about she was reluctant, but then she realized how important she was as the parent, and it kind of changed her behavior in what she was focusing on and realized how important she was. And the last one is saying the same thing. We as parents are learning more skills than ever. And that's somebody who I believe experienced both. And if we hear quotes like that, we go, yay, because that's really what the essence of New Jersey's early intervention system is. Okay, how is a child eligible? So there's two paths to eligibility. A child has to have a measured developmental delay in either one or two or more areas of development. So if it's one area of development, it's 2 standard deviations below the mean, and it's 1.5 standard deviations if it's 2 hours. And I'll talk a little more about that in a minute. Even if a child's not showing a delay but has a diagnosis, this is where the healthcare providers may come in, that can establish their eligibility if there's written documentation of a diagnosis and a statement that that diagnosis is typically resulting in developmental delay. And you see some of the categories there, chromosomal abnormalities, sensory impairments, those are the words from the federal regulations. Importantly, we don't serve children who are at risk for developmental delays, but that doesn't mean we don't necessarily want them to be referred. So identifying the children who are at risk and making sure that they get to early intervention sooner is always important to kind of keep an eye on development. I'm also doing a time check for myself, so I'm going to move on. These are the diagnoses that are presumed to be eligible as long as there's documentation of the diagnosis. Again, we don't need a diagnosis or for eligibility, but there are some children that can establish eligibility in absence of the delay. Understanding the standard scores, so bell curve. I put yellow is the 1.5 standard deviations, orange is the 2 standard deviations. So we're really thinking about kids who, you know, if you think about 1 standard deviation as the 16th percentile, we're really talking about referring kids kind of here with the concerns. So which ones do you have a concern about? Again, you don't have to know there's a developmental delay, you just have to have a concern in order to share information with the family about referral. And then we connect families with resources, and I think I mentioned this, even if they're not eligible, our evaluation teams do talk with families and write up really nice strategies and suggestions for how to support development, as well as connect families to other resources. I'm going to go a little more quickly now. The ongoing service coordinator, I said, is that point person, and you could see the meetings that he or she, but most of them are she's, really conduct the plan and connect the families both to the early intervention resources as well as the community resources. And then it talks, I talked about this already a little bit, what that family directed assessment is, trying to get a sense of the everyday activities and routines of the family. Just wanted to mention, and then that's what we use to develop the IFSP. Just wanted to mention the system of payments. Probably more than 60% of our families do not have a cost share. However, we do have a process to determine what's called a family's ability to pay. You see the criteria on the slide. The cost share applies to ongoing services. It's never more than the actual cost, and it's never for the public expense services. So if you just kind of review that, just to give you a sense, they show documentation, and the service coordinator, you know, plugs it in, and there's a calculation based on these criteria. So family of 4 making $76,000 a year, their cost share starts around $2 an hour. So it's pretty reasonable, and then it goes up from there. This is the IFSP team. It's always that triangle of communication, family, practitioners, evaluators, and the service coordinator making decisions. And of course, the family can invite healthcare providers, childcare providers, grandma, anybody that they want to come to the team meeting or contribute. And then the IFSP, I think I talked a little bit about it, but it's a written plan describing the child's current developmental levels, addressing strengths and needs, and really geared toward the family's priorities and what is happening within their life and what they want to see happen. And so that's really, it's really the family's goals and outcomes we work towards. These are the most common types of early intervention services. I just wanted to highlight, there are a few more, but these are the I would say highest percentage ones. Wanted to highlight a little bit about developmental intervention just because it's probably not a service you may have heard of. And if you kind of look at the bullets there, it talks about, this is really one of our core services, and any of our disciplines can provide developmental intervention, OT, PT, speech, child development specialist, all those people I mentioned could provide it depending on, you know, what the strategies are and the needs of the child and family. But it's really a lot about planning and intervening, designing activities, and providing families with information. So you may hear about this. We may be working on the child's receptive communication skills through developmental intervention, or their expressive communication through developmental intervention. So we can talk a little more about that at a later point. We also have a process for reviewing the plan whenever is needed at required times of 6 months and a year, but whenever we need to review the plan, we do so. And then I just wanted to wrap up with just summarizing what we think of as the early intervention state of mind, or the family engagement model. We do work in natural environments, so places where all children and families are, where they live, work, worship, play. It's really about the learning opportunities within their routines and activities. And I know I'm going quickly, but these slides sort of all go with the same conversation. So you bath time, diapering, going to the park, grocery store. So when we're doing right now we're doing telehealth. When we're doing our telehealth, we might be planning with the family the things they're gonna do when they take a walk, staying far away from everybody, those kinds of things. Or if a child does have to wear, if a parent has to wear a mask and it scares the child, maybe we're going to work on how can we help make that fun, help them color, you know, and kind of get used to it. So there's lots of things we can do, but we really truly believe by focusing our efforts on families, an hour of intervention can identify many, many, many opportunities for learning throughout the child's everyday life. So we kind of think of this as the 1 to 84. 1 hour of service influences potentially 84 waking hours of child's development, because we know that the nurturing relationships and the partnerships and enhancing the capacity of families, we know that's what builds babies' brains. A few more quotes I'll let you kind of look at after the session, but I really like how the family is saying they feel like they're even more effective by getting their whole family involved and getting knowledge on things they can do to help their child. And then these slides just kind of talk a little bit about, we do work with families on when they leave us, and I'll let you peruse those as well because we want to give a few minutes for questions. Building connections to the community, again, at an individual level for a family, also at a system level is what we do. And then Dr. Holohan talked about risk factors. So just keeping your eye out for kids who have adverse child experiences. We know that any of these and children who've had these experiences are at higher risk for developmental delay. So there are actually some requirements around them getting referred through protective services through early intervention, but just kind of included it for you to keep an eye out during your developmental surveillance and screening. These are the brochures that on the right that I mentioned, and some of the posters as well that we'd be happy to provide you. They're also on the DOH website. You're going to get all these links in the next couple of days. And I just wanted to highlight the Family Matters website. .org is a really great place you can refer families to. There's lots of nice information there, videos, information about how we're functioning, what telehealth might look like. So there's really resources for families. And then I just wanted to end there's additional resources at the end, but I just wanted to kind of end by thanking you for being part of a child's village and a family's village, that individually we're one drop, but together we're an ocean. I really feel like this captures the work that we do and how we can support families. We'll take questions, but I just wanted to really quick show you, I'm just going to click through. There's additional resources at the end about where you can find out about child development, the CDC websites, the AAP websites for developmental surveillance screening, et cetera. And if we want to take, is someone going to kind of look at the questions and see?
Yes.
Okay,
yes.
thank you.
So thank you, Drs. Hallahan and McConnell, for your outstanding presentation today. Once again, if you do have questions, please type them into the Q&A box located at the bottom or the top of your screen. And if you have additional questions after this webinar, please feel free to email us at njchapter@njaap.org, and we will share those with our presenters and get back to you with their responses. So at this time, we'll entertain a few questions. So the first question is, are there any screenings in development literally to identify autism earlier than 18 months? Or is there a screen for 12 months perhaps?
No, there's not a specific screen for autism that I'm aware of that's meant for very young children. But the developmental screening instruments like Ages and Stages, for instance, that look at different areas will pick up problems with expressive language, receptive language, social, emotional development much earlier, even earlier than 1 year.
Thank you. The next question, how can we get pediatricians to review a CDC milestone checklist without parents bringing it up?
I guess that's the reason we're having a session like this, is to encourage physicians maybe who aren't doing it to be more proactive in initiating the encouragement of families to utilize developmental checklists themselves at home, to highlight the importance of development, to promote developmental knowledge, and to increase the likelihood they'll bring up their concerns. You know, the data does show that from, I think, 2010 roughly to 2016, the percentage of pediatricians conducting formal developmental screening went up from 23% to something like 61%. I may not be exactly right, but there was a very nice jump. There's still maybe a 40% or so who still, at least back in 2016, still need to incorporate developmental surveillance and screening into their practice on a routine basis.
Yeah, that's great. I just wanted to add too, some of the encouraging families to use some of the apps and information about development so they can track their child's development. Like I know there's that Milestone app from the CDC, also gives an opportunity for them to kind of track it before there's anything that comes up. So that might give you a way to kind of start the conversation as well.
Mm-hmm. Thank you. The next question is, evaluations to developmental peds takes very long time. Is there a way to work to alleviate the logjam and shorten the wait?
Well, that's a problem. And I'll say a couple of things about that quickly. That's the one reason too that we don't want primary care physicians to wait for the developmental evaluation before they're referred to early intervention. And I'd say 15 years ago, the majority of children we saw who finally did get in for developmental evaluation were not yet referred to early intervention. Now, the vast majority are already referred to early intervention, so they're getting services. So at least they're not missing out on key important services. There's a strong emphasis around the country in trying to encourage young physicians to get into developmental medicine. I know programs like ours really work hard to recognize when families are probably not going to be able to come in for an appointment, when there's a cancellation, and bring in other children in that spot. And the emphasis is on young children, and especially children who sound like they might be on the spectrum.
Thank you. So this question is for Jennifer. Jennifer, those materials that you shared, are they both in English and Spanish and other languages?
The developmental brochures and posters are in English and Spanish, and they're on the Department of Health's website. And you can also contact one of the regional early intervention collaboratives as well to provide the brochures and the, the folded up, but the actual, there's a link for it. So yeah, it's just English and Spanish right now.
Thank you. I think we have time for one more question. Looking at the time here. Would it not be better if pediatricians performed a screening instead of surveillance on every well visit?
I think when you look at everything, the combination of surveillance with designated screening at those times that I highlighted, or whenever you're concerned with the surveillance, is actually more effective in the long run. And if parents are using questionnaires at home, like I mentioned and Jennifer mentioned, they're really following screening type guidelines to some extent as well. So I think that when they really look at the overall data and what's feasible for physicians and offices, this approach is very effective when both surveillance and screening are used collaboratively together.
Yeah, and I think we just want to collaborate. The family's the decision maker, so they get to choose what information they share, but our teams are usually, hopefully, thinking about the child and family as sort of in that one that had the different spokes on a wheel, that we want to encourage collaboration and coordination of care. So, sharing information, we're happy to provide additional information. We do lots of, my teammates do lots of presentations and outreach to different folks, but as long as the family's in agreement and signs consent to share reports and things, we do that. So our teams do talk about that with families. I was addressing a question, sort of.
If I could just go back 1 second.
Yeah.
In, I think the last issue of the pediatric, of the journal Pediatrics, someone did raise a question, why don't we do formal developmental screening at 24 months in addition to 18 and 30 months? And there was a wonderful response to it that really highlighted the rationale for the way it's set up right now.
All right, well, thank you. I see we've reached our time. So again, on behalf of the New Jersey chapter of the American Academy of Pediatrics, I would like to thank you all for joining us today for this webinar. Again, we thank National American Academy of Pediatrics for their support. And as mentioned previously, CME and MOC Part 2 credits are being awarded for your participation in today's webinar. The webinar quiz will show in your browser at the conclusion of this webinar, and a link to the same webinar quiz will be emailed to you tomorrow if you are unable to complete the quiz immediately following our webinar today. So once your quiz is submitted, your credits will be issued, and you can expect a certificate emailed to you over the next 30 days. As a reminder, this webinar has been recorded and will be made available on the NJAAP website. The information to access the webinar will be sent to you in tomorrow's email. We do hope that you will join us again on July 8th at 1 p.m. for our second Think Babies webinar. The title is The Impact of COVID-19 on Child Nutrition. Thank you and have a great afternoon. This concludes our webinar.
Thank you, everyone. Stay healthy, stay safe.
Thank you.